Welcome to our DDU session. Today's topic is pericardial assessment by echocardiography. During this session, I'll be talking about pericarditis, effusions, tamponade, and constrictive pericarditis. I'll basically be talking about the echo features of all of these, and I won't be talking much about etiology or medical progress in that respect. Yeah. So this is a very good guidelines document published in 2013 by the American Society of Echocardiography. It has some really nice pictures of the anatomy and the histology and the function of the pericardium, as well as various comments on the pathology. So it's well worth looking up. So just as a quick reminder, a normal pericardium on echo is a thin, bright line around the myocardium, and it should be less than 2 millimeters in depth. So when you're looking at an image like this, characteristically in the parasternal long, you have to be careful that you don't have your gain turned up too high in the far field. Otherwise, it might give you a false impression of how bright the pericardial line is. So this is our first case. We have a young woman who presents to ED with sharp chest pain that's worse on movement, but eased by sitting up. And she has widespread elevation of ST on her ECG. Kalpana, what are your thoughts when you see this?
So I'll be looking at the history. Regional wall motion abnormalities.
No. So what? Just on this picture.
On this picture, I can see that the RV and LV contraction is looking good.
Yep.
RV. So this is the parasternal long axis view. You can see RVOT. We can see the aorta and left atrium, and there is actually like bright pericardial shadow, but like should not be more than 2 millimeters, I guess.
Okay, so if I stop,
we'll have to measure it.
Yeah, we'll have to measure it. But in actual fact, if you take from here to here, then it's a little bit thickened. Yeah, it's more than 2 millimeters. So if you have somebody who comes into your hospital with a history that's suggestive of pericarditis, then it's now recommended that you get an echocardiogram within 24 hours. But the actual features in a straightforward pericarditis might be quite diverse. In some people, the echo will actually be normal. In some, you'll have some thickening and increased pericardial brightness. You may have an effusion, which is usually not going to have tamponade, but may well. And if there's myocardial involvement, then you may get segmental wall motion abnormality. So myocarditis looks bright on echo.
So this side thing will be pericarditis.
Yeah. So it's consistent with pericarditis, but as you can tell, there's no effusion associated with it in this view. So if you're going to find a pericardial effusion, there are certain characteristics of that effusion that you need to comment on. The first one is the size, and we'll go into that in the next slide. The second is the location, and basically the effusion can be circumferential or it can be localized or loculated. And if it's localized, then it might well be hematoma or pus or just a pericardial cyst. You also need to comment on the appearance. So in general, it's going to be either echo-free, i.e. black, versus echogenic, which has echogenic material floating around in it. And again, if that's the case, you would think about pus or blood or tumour as the options. And if you have an effusion, then it's worthwhile commenting on whether or not you think it's associated with tamponade. So when we have an echo free space, as in on the left, that is highly suggestive of a transudate, whereas you can see that there's lots of fibrin strands. That counts as echogenic and suggests that there's either clotted blood or inflammation in the pericardial space. When we look at the size of an infusion, you basically take a perpendicular measure through the pericardial effusion at the end of diastole when it is actually supposedly at its smallest. And if that measurement is less than 1 centimetre, then it suggests that the volume is less than 100 mil. If it's between 1 and 2 centimetres, that counts as moderate, and generally the size will be 100 to 500 mil. And if it's larger than 2 centimetres, then it's probably more than half a litre. However, the volume will not necessarily correlate with any clinical symptoms.
Louise, can I just ask there? So measuring at end diastole, when in theory you're capturing your smallest volume because your LV should be at its fullest, ready to go. But that's if you're measuring it between the pericardium and the ventricle. If you're measuring it
And the myocardium.
Sorry, yeah.
Yeah.
If you're measuring it around the site of the atria rather than at where the ventricle is, if you're trying to gauge the depth of a pericardial effusion between the atria and the pericardium, at end diastole, your atria is probably going to be, it won't be its
Bigger.
fullest. Yeah.
Yeah. So,
Because if you're looking for atrial chamber collapse from the pericardial effusion, the timing and measure could be different, couldn't it? This is right.
no, I think so. Basically, what you would do is you would take the largest measurement in whatever view you saw.
Yeah.
And it doesn't really matter so much about where you take the measurement from. But I take your point. So the prognosis of an effusion is often related to the etiology. For example, in the Framingham study, it was actually fairly common to find asymptomatic pericardial effusions as people got older. So particularly in elderly women, and more than 10% of these actually had asymptomatic pericardial effusions. And if you then exclude metabolic causes and hypothyroidism, and the effusion is stable when you follow up somebody with a repeat echocardiography, it's labelled idiopathic and no further investigation or treatment is warranted. If the effusion is large and initially asymptomatic, the prognosis is less favourable because these patients often have occult malignancies or pericardial inflammation. And under those circumstances, you probably need to tap that pericardial effusion to get more information about it, or send the patient off for CT or MRI, or all of the above. So the location, you can see it, you can usually see a genuine effusion in multiple views. And if you see this distributed in all your views, then when you actually measure the size with the perpendicular measurement, it's going to be more reliable than if you have a very small or a very large effusion. So, but there are a lot of mimics to pericardial effusion, and the common ones that we have difficulty distinguishing may be a pleural effusion, particularly if it's very small, epicardial fat, and ascites. And I'll show examples of these. Less commonly, it may mimic, a pericardial cyst may mimic an effusion, or even an anterior mediastinal tumour, particularly if it's got a necrotic center. So pleural versus pericardial effusion. You really need to find your descending aorta, and basically the pericardial fluid sits in front of the descending aorta and is separated from by the left atrium. Pleural effusions are always posterior to the aorta, but you can see in the diagram on the right, you can see how easy it is to actually make it difficult for yourself.
Increase your depth and look for the
Yes.
floating lung.
Yeah.
Yeah.
Now with ascites, if you're doing the subcostal view, you can actually see that there's a midline falciform ligament.
yes.
Oh, nice.
Yes.
Yeah.
Yes, like,
So here's somebody who just has ascites.
Yeah.
And here's somebody who has a pericardial effusion
and
and
ascites.
ascites, because they can often coexist.
Yeah, that's a nice picture.
Now, epicardial fat can sometimes be quite difficult to distinguish. So the important things to think about are, if it's epicardial fat, it's generally going to be anterior only.
Yep.
And the other thing is, if you can see the speckled appearance across there, you'll see the whole epicardial fat actually move with the myocardium. And that's a good clue that it's just fat.
I remember being worried a lot of times when I first started, like, oh, is there an effusion? Oh, is there an effusion? I'm not worried, excited. And then it's bad.
The degree of echogenicity of fat can be a bit variable,
Yeah.
and it may often be brighter than the myocardium, but there'll always be some speckles in it.
Yeah, I think like the pericardial effusions which I have seen they are not complicated, so
Yeah,
they look
much
like
more
echo
anechoic.
free.
Yeah.
Yeah, so. But yes, if they're complicated, then it will become problematic too.
So moving on to cardiac tamponade. So a brief definition of cardiac tamponade is that we have an accumulation of fluid under pressure in the pericardial space that restricts diastolic filling. However, there are a couple of versions of tamponade that you need to be aware of. One is so-called low pressure tamponade and the other is regional tamponade. But first we'll go through the physiology. So when you take a breath in, your systemic venous return increases. However, the right ventricle can't fully expand because of the pressure exerted by the pericardial fluid. So the interventricular septum will bulge to the left, and the pressure in the pulmonary veins will also be less than intracardiac pressures. Because of that, what you will find is that there is a strong respiratory component to the inflows on either side of the heart. So during inspiration, the maximum inflow is through the tricuspid valve. However, the septal bulge into the left ventricle is not specific for tamponade. You can often see something like this when you have somebody who's short of breath for metabolic disorders or even COPD or pulmonary embolism, in which case the absence of a pericardial effusion might be the best clue that it's not tamponade. Pulses. So this actually fulfills criteria for increased interventricular dependence when you have the movement of the septum. And if you have impaired diastolic filling of the left ventricle during inspiration, that can sometimes, but not very often, give rise to pulsus paradoxus. Now, pulsus paradoxus is the drop greater than 10 millimeters of mercury on your systolic blood pressure during inspiration. But in actual fact, it's not a paradox because it happens to a very small amount under usual circumstances. But I don't know why it was called paradoxus. The other thing to actually think about is electrical alternans is a traditional ECG sign of tamponade. And basically what happens is there you can imagine the heart that's moving inside the pericardial fluid, and it moves closer and then further and then closer and then further. And that's why you get different sizes to the QRS. So the reverse happens during expiration. The intrapericardial pressures are greater than the right-sided chamber pressure. So you get right atrial and right ventricular diastolic collapse, and we'll go into that a bit more in subsequent slides. You also get hepatic vein expiratory diastolic flow reversal, which is a bit of a mouthful. And so during expiration, the actual volume in terms of mitral inflow is greater during expiration than the right side. Now, whether or not you get tamponade with a specific pericardial effusion, it depends not only on the amount of fluid, but also the speed with which that fluid accumulates. Because if it accumulates slowly, the pericardium has time to distend itself, and you can, for example, with malignant effusions, have very large volumes of fluid that aren't particularly causing any degree of tamponade. So there are some sensitivities and specificities that have been worked out for the individual signs of cardiac tamponade. And you can see that the best one is actually duration of diastolic collapse of the right atrium as a proportion of the total cardiac cycle. If it's more than a third, then that's a pretty specific sign for tamponade. It's also fairly sensitive, given that it's a fairly advanced sign. But diastolic collapse of the right ventricle isn't bad. On the contrary, you can see that inferior vena cava plethora, that is a dilated vena cava that doesn't collapse appropriately with inspiration, isn't particularly specific. And there are lots of other conditions that will give you what's called IVC plethora.
And if someone's mechanically ventilated and you're...
We'll come on to that. We'll come on to that. So RA diastolic collapse is best seen in your apical four-chamber or subcostal. It actually starts appearing first in late diastole near the peak of the R wave. And this is because this is when the volume is actually minimal during the atrial relaxation phase and the pericardial pressure is maximal. And the right atrium will stay indented until enough filling has occurred during ventricular systole to increase its pressure above that of the pericardial pressure.
So greater than a third of the cycle, which is the time like you had on the previous slide.
Yeah.
Yeah, 0.34.
So basically you have to scroll through.
Yeah.
It's not so much the significance of the collapse, because any collapse that you can actually see is significant, but it's the duration, and you have to scroll through watching your marker go along the ECG, and then you can work out. So you need to have good, hang on, where's it gone? You need to have good ECG pickup for that. So RV collapse occurs early, relatively early in diastole, and it might not actually happen if you already have a hypertrophied right ventricle. So, for example, if you had pre-existing pulmonary hypertension, you might not see the RV collapse. Initially, as the tamponade begins, it'll only be seen during inspiration, but then as it gets worse, it'll be seen throughout the whole of the respiratory cycle. And M mode, through the subcostal view and the free wall of the right ventricle, is very good at picking this up, and it also allows you to time it quite well. And you can see the dipping of the wall occurs during early diastole. If there's no right atrial or right ventricular chamber collapse, we can be more than 90% sure that there's no tamponade. But again, the caveat is unless you have pre-existing pulmonary hypertension or even severe left ventricular dysfunction. Now, there are various Doppler features of tamponade that you can detect by looking at the inflow of the tricuspid valve and the mitral valve. So let's start by having a look at the mitral valve inflow. If you just measure at the beginning of inspiration, so this is a standard respiratory recording. So this is inspiration here. Oh, it's not doing it, sorry. Inspiration here, and this is expiration here. So you take the first beat after inspiration starts, and you take the first beat after expiration starts, like that, and you compare their relative sizes. And if there's a decrease in mitral inflow velocity with the E wave at of more than 25%, then that is considered highly significant. And for tricuspid, though, you need a 40% difference, and the timing has to be appropriate. So inspiratory decrease in mitral inflow and inspiratory increase in tricuspid inflow. And what?
I was saying, and that's for the mitral, that will be stemming from that interventricular dependence, right?
Yes.
The septum moving over.
Yeah. Well, not exactly, actually, but it's near enough.
Near enough.
Near enough, yes. So the normal E wave variation is less than 5%. And the changes in isovolumetric relaxation time are minimal. With tamponade, if you are measuring the isovolumetric relaxation time, it will have increased. The timing of the maximum change is different between tamponade and COPD. So if you do have somebody with airways disease, it's not actually the first beat that's lowest in inspiration for COPD, and it's not the first beat during expiration either.
Just to make it fun.
Just to make it fun.
Like a board's exam question.
Now, when you measure the hepatic vein, venous Doppler, you will often find that the hepatic vein is relatively dilated, which is what you should expect. Your IVC should be dilated more than the 2.1 centimetres, and it should drop less than 50% with spontaneous inspiration. If you have somebody who has low pressure tamponade, then what you will find is that the main problem is actually hypovolemia. And under those circumstances, you would expect a reasonably small IVC that collapses completely, say about 1.2 centimetres or thereabouts. If you measure the hepatic venous flow, what you will see is that in general, all the venous velocities are decreased. So our normal hepatic venous flow is 50 centimetres a second or thereabouts. And you will find that that is actually halved during tamponade. So here you can see the peak systolic velocity is around about 20. If somebody was apneic, you would only get systolic flow. If somebody is taking a breath in, you would expect the systolic flow to be greater than diastolic. And during expiration, you would expect the diastolic flow to be reduced or even reversed. So you can see that matching inspiration here and expiration there. And there's the diastolic flow reversal. So this reversal is at the same time that tricuspid inflow is the lowest. It's interesting that although you can see this relatively easily in the hepatic vein, there's less variation in your superior vena cava, where you never quite lose your diastolic flow.
Gravity.
Well, that depends if you're vertical.
If you're sitting more than that.
Yeah. Most people who have echoes are usually just lying on their side.
Yeah.
Or
Still
their
gravity
legs.
if you're moving on the right. Yeah, if you're coming from here, that's down there.
So this Doppler finding will be quite unreliable, obviously, if you've got atrial fibrillation. If you have major tricuspid regurgitation, forget it.
Yeah.
And if you have a paced rhythm or a severe bundle branch block, you might not get a very good tracing.
Sam's into the waiting.
So when we, hello Sam, when we refer to localized collections, quite often what we mean is patients who've got tamponade due to hematoma post-cardiac surgery. And quite often that's going to be behind the right atrium, and it's very difficult to see that with a transthoracic. So if you are considering that somebody post bypass has a problem, then you really should do a transesophageal echo.
In bypass, you won't even get very good views
From all the scarring, drains, staples, sutures, blood.
Well, that's a transthoracic views.
Yeah.
Shit, but
Yeah, transthoracic.
Yeah.
but also because you can see behind the atrium a bit better. Oh, well, what happens when we actually embark on mechanical ventilation? I'm afraid the news is not good. Pleural pressure becomes positive and is transmitted to the pericardium and heart chambers. Therefore, pericardial pressure will rise, right atrium and right ventricular transmural pressure will fall, and you generally get a further fall in cardiac output, which is mostly due to the decrease in the right ventricular end diastolic transmural pressure, and also further loss of right ventricular preload. During mechanical inspiration, there's a theoretical increase in left ventricular stroke volume, and you may see an increase in the systemic arterial pressure at the end of inspiration. So what that means is that when you're ventilating somebody, you need to try and reduce the amount of positive pressure, use smaller, more frequent tidal volumes and minimal PEEP if you can get away with it. However, it does mean that all the Doppler measurements you have taken are now unreliable in terms of the diagnosis of tamponade. You may even have a suppressed or reversed pulsus paradoxus. Never say that this DDU teaching program is without culture. It's in French, you know. So I'm going to say a few things about constrictive pericarditis. Now, this is impedance to diastolic filling that's caused by inflammation and tightening or fibrosis of the pericardium. It doesn't always mean that it's not irreversible if for example, it's got an inflammatory course and it's relatively early in the disease, you can sometimes treat it with steroids and get resolution of the constriction. So when we think about constrictive pericarditis, you will often see pericardial thickening, but there will be 20% of people who don't have pericardial thickening. It isn't usually associated with an effusion unless you've got a mixture of effusion and constrictive pericarditis, but you will see the same exaggerated ventricular interdependence. So the first thing to look for is the respiratory bounce of the interventricular septum. You will then get respiratory variation in the mitral E velocity and tricuspid E velocity, much the same as with tamponade. Your IVC will also be fixed and dilated. And you will also see the hepatic vein flow, diastolic flow reversal during expiration. However, what's different about constrictive pericarditis is that longitudinal strain of the myocardium is preserved, and it's circumferential strain that is reduced by the coat around the actual ventricular muscle. So there is a sign that's very suggestive of constrictive pericarditis, where you have an increased or normal septal E prime wave, and the lateral E prime is reduced because that is where it's most affected by the constriction of the pericardium. So this is an example of what you might see with pericardial thickening. And this is an example of the hepatic vein expiratory diastolic flow reversal. So again, measure during the first beat that happens at the beginning of inspiration. So here we have the systolic wave, the diastolic wave, systolic, diastolic, systolic, and then we get flow reversal during diastole, which is more prominent during expiration.
Yeah.
Now, this is a very interesting diagram that I found, I think, in some article or other. And basically, it shows you how the E and E prime are preserved when you have constriction. But when you have restriction, you will see a different pattern. This is one of those cases where a picture is worth 1,000 words, isn't it? The E wave is actually exaggerated in constrictive pericarditis because the longitudinal movement of the myocardium increases with circumferential restriction. So early diastolic filling in constriction is more rapid than normal because the restraining effect of the myocardium does not start until after mid-diastole, during which little filling occurs even with atrial contraction. So what happens if you have a patient who you think might have tamponade, or it might be an effusive constriction? Well, apart from those differences that we've just already mentioned, the other thing to do would be to drain the effusion and then see what you're left with. If it's just pure tamponade, then your echo should return to baseline. And if it's effusion constriction, then you'll have persistent right-sided atrial pressure. And this is an example of the changes that you might expect to occur if you have an effusion constriction and you drain the effusion. So A, B, and C diagrams are before drainage, And in B, you can see that the E wave is dominant and the EA ratio is greater than 2. In C, you can see that there's absent diastolic forward flow in the hepatic vein and diastolic reversal during expiration. And then what happens after you actually drain the effusion, but you're still left with constrictive pericarditis? In E, the mitral inflow is still restricted. Your E wave is greater and your EA ratio is probably pretty close to 2. And in F, you have restoration of the diastolic forward flow in the hepatic vein, but then you still have marked expiratory diastolic flow reversals. Now, constrictive pericarditis has features that are similar to a restrictive cardiomyopathy, such as endomyocardial fibrosis or amyloidosis. They both have diastolic problems and relatively preserved systolic function. So the characteristics of a restricted filling pattern through the mitral valve inflow are going to be a very high peak E wave, an increased EA ratio, a short mitral valve deceleration time, which is normally over 200 milliseconds. It'll be less than 160 milliseconds. And that is because the pressure equalizes rapidly over the mitral valve as pressure builds up in the left ventricle. In both, you will still have a plethoric IVC. So what distinguishes constrictive pericarditis from a restrictive cardiomyopathy are that you get this exaggerated respiratory effect on all the parameters we've mentioned. You get movement of the interventricular septum. Your pulmonary S and D waves are approximately equal with constriction, whereas the D wave is greater than the systolic wave when you've got restrictive cardiomyopathy. And last and most importantly is that you've got normal mitral valve annular Doppler velocities, i.e. your E prime is normal in constriction, but low in restrictive cardiomyopathy. So there's also another interesting test that you can do by putting your colour M mode through the mitral valve flow. And I've got a picture of that. So if you put your colour box across all of the left ventricle, and then you put the cursor through the centre of the flow, and put it on M mode, you will get a picture like this. And the early flow here, this is the E wave, and this is the A wave. And this early flow here, where you can actually measure the slope of the aliasing velocity, is related to relaxation of the ventricle. So it's actually quite a good way to actually look at the process of relaxation. And it's said that using this as a measurement is preload independent, or at least it's preload independent in dogs. And normally if you measure the slope, a normal result will be greater than 50 centimetres a second. So if it's less than 50 centimetres a second, then you can infer that the relaxation of the ventricle is abnormal. So my take-home messages are, you basically have to identify the underlying cause for the pericardial disease and be aware that any effusion potentially can cause tamponade. And so you would be looking for these particular criteria. However, sometimes when you have an effusion, you actually do have underlying constrictive pericarditis, And so you need to repeat the echo once you've actually drained the effusion and see if there are any signs of that. Now we're going to go to some cases. So what I'm going to get one of you to do is to come and run the show so that you go through the images at your own pace. You up for it, Ben?
Yeah, of course.
Okay, so I'll just tell you this one. First one, 37-year-old man. He's IV heroin user. He had a recent admission for Staphylococcus bacteremia, discharged himself, then felt unwell and came back. And he complains of 3 days of shortness of breath and dull chest pain. So would you like to drive it so you can look at,
Yeah.
just stop at the slide that says,
You tell
what
me
do
when.
you think?
You tell me when to stop.
No, I have
Okay.
put sign up saying, what do you think?
Okay.
You have to stop there.
And so this echo was done when he's presented here 1 week later, right?
Yep.
Yeah. These clips? Yep.
Yep.
Right. So I'm looking at a parasternal short axis at the level of the mitral valve. There's some striking abnormalities on this first scan. To start with from top to bottom, there looks to be a small pericardial effusion that is probably present throughout systole and diastole. The right ventricle, it looks to be thickened and dilated. That appears to be a moderated band, but it may be a muscle associated with the tricuspid valve. Coming down to the left ventricle, there is certainly a septal bounce and systolic flattening of the interventricular septum, suggestive of right ventricular pressure overload. There may well be diastolic flattening as well, but I don't think it's consistent. I can't see any lesions associated with the mitral valve because I will be suspicious for infective endocarditis. And I'm less suspicious of this thing up the top here in the right ventricle being a infective nidus on this view, but I need to see more views. Otherwise, I can't appreciate any significant regional wall motion abnormalities.
Okay, move on.
Move on.
That was a nice summary.
So we've now transitioned to a apical 4 chamber that is relatively well on axis because I can see the pulmonary vein. So there are, once more, multiple abnormalities in this film. The most striking abnormality is the presence of a large circumferential pericardial effusion that appears to be quite exudative in nature with echo-dense material floating in it. I'm assuming they don't have a pericardial line and you have given bubbles because that would be
No.
differential here.
No,
Okay, no, good.
no, that's all his own work.
So I'm very much now concerned for any infected pericardial effusion, and this may very well be pus by this point. With regards to the remainder of the scan or the segment that I can see, so he's got left and right. He appears to have left and right ventricular collapse. Can I slow it down? Let's try this. Okay, cool. So in systole, the anterolateral wall of the left ventricle is perhaps collapsing in a little bit.
Yeah.
So he's got impaired left ventricular, or abnormal left ventricular motion because of the presence of the fluid around the heart. With regards to the right ventricle, with regards to left ventricle for a second, otherwise contractile function is broaching on hyperdynamic. With regards to the right ventricle, it's significantly dilated, it's heavily trabeculated, and it's apex forming. It's got preserved lateral contractility, but its apex is certainly not contracting. There is probably a vegetation associated with the tricuspid valve in this view through here. But the heart's moving so much at a rate of 120, it's hard to be sure. both atria appear enlarged, and the left atrium appears to be collapsing in. I just need to phase it in the cardiac cycle. Probably through the marker there. So in early diastole, there's some left atrial collapse, and the right atrium is not as convincing for collapse.
Okay, move on.
We go. We've got a measure now, 1.7 centimeters at the apex. Okay. So that puts it into the
5
moderate category. But again, I think this reflects the limitation of this view, is that I think it's actually going to be large.
No, that's actually the biggest measurement I've had.
The big, oh really?
Yeah.
It looked bigger.
It looked bigger on the apical four-chamber,
Yeah.
but it wasn't actually. It was even slightly smaller.
Right, well there you go.
There you go.
Stand corrected. So I've now got a handily labeled tricuspid valve TDI. So this is a pulse wave cursor put through the tricuspid valve inflow on an apical forward chamber, ideally an RV focused, and color Doppler to help with alignment. So what I'm looking for here is the presence of variation in the tricuspid valve inflow between inspiration and expiration. I'm looking for variation greater than 40%, where on the tricuspid valve, that will be an increase with inspiration. And what I've got here with this, they're the
So
same.
the numbers are up in the left-hand
Oh, yeah.
corner. And
There we go.
it's
They're identical.
Yeah.
So no
6
variation,
centimeters.
which
a second.
goes, so when the variation is greater than 40%, then that is contributory to the diagnosis of tamponade in the right clinical context. Was he shocked? I can't remember if that was this time. So I'm now looking at a subcostal, four-chamber subcostal. So I'll let it play. So the most striking feature here does appear to be some right atrial and certainly right ventricular collapse. I can't appreciate left ventricular or left atrial significant diastolic or systolic collapse in this view. I'm going to pause it just so I can get the timing right. So with regards to the right atrium, I'm not quite catching the end of it there. So at the start, end of diastole here, it's not quite collapsing a bit. Start of diastole, when it's at its fullest, it's holding its own shape, but the right ventricle is collapsed down and systole start of diastole there. And is that a lesion on the tricuspid valve? I'm not convinced that that's a vegetation on the tricuspid valve.
But you note he's got quite a big moderator band on that.
Yeah, flicking in there, which I could see on that very first
Even
image.
in the first one.
Yeah, in that first shot. And again, here on the mitral valve, that's more suspicious, but I think I'm catching a pat muscle and a chordae. Color flow from the same view as before, with the focus over the left and right atrium. I'd like to turn the color scale down to get a better idea if there's an intraatrial shunt.
No, there wasn't.
There wasn't, thank you. Otherwise, all I can see is significant TR, and that's. So I've got tricuspid regurgitation. That is at least moderate, if not large. I'd like to pulse the hepatic veins and get a cursor, continue to cursor through there to get the maximum velocity. That's probably mitral regurgitation I'm seeing as well, but on this angle, I'd need to be sure I'm not catching anything to do with the left ventricular upper tract nerve. Again, there's the circumferential pericardial effusion, sonographic features of tamponade and epidense material within that fluid, and the RV free wall is thickened as I saw previously. Final shot is the IVC, that is approximately 2 centimeters with variation of less than 50% on inspiration, let's say. And I would, again, here I can see nicely the pericardial effusion. I can't see any ascites. the RA is likely collapsing, and I believe that what could be considered as particulate matter within the IVC is probably just echo artifact. 2.1 centimeters, less than 50% collapsibility, but he had significant tricuspid regurgitation, so I'd expect a dilated IVC and perhaps less than 50% collapsibility. So
Yeah, so it's actually confounded, isn't it?
yeah.
So I thought the most likely cause of his right ventricular problems were actually long-standing and due to
He's got long-standing pulmonary hypertension,
probably secondary to
Yeah.
recurrent PEs.
so I think that he's got a exudative infected pericardial effusion, sonographic features of tamponade. I need to see what it's like in front of me to call it clinically, but more importantly, it's got to come out because it's got pus in the pericardial space. I'm not certain, I wouldn't say for certain that I saw vegetation on any of his valves, so he'd need a transesophageal echo to exclude infective endocarditis, so that's quite likely.
Okay, move on to the next slide. There's a postscript.
Yeah, pericardial MRSA or over, yeah, okay. Nuclear much valve, LV wall abscesses, and multiple septic cerebral emboli, and multiple lung abscesses. 10 days later, you gave me to someone else. Ideal management.
Yeah. Married to mate in heaven.
Good case.
You want to have a go to the next one?
Oh, okay.
Were you
Will
involved in this
help.
care?
Our partner will help.
Okay, yes, please help me.
So let me just move on to the next one.
Right.
Okay, so this is the clinical context.
Syrian refugee with developmental delay. Yay, that sounds like fun. Okay. Recent acute major bleeding into the liver, tachycardic, failed embolization twice, massive hepatic angioma. Okay, on 20 minutes.
So while you're thinking, always identify the view. And
So
then
we got a
basically go from top to bottom.
so we have a parasternal long axis view. The first thing that I can see is that she's got, I can't obviously say that it's circumferential, but it looks to be like she's got a circumferential pericardial effusion, and she's got some kind of echogenic material. It's so at the most anterior aspect of the view. The RV doesn't look enlarged. It looks like it's contracting well. The aortic root looks pretty dilated to my eyes, but I could be...
So upper limit might be, I don't know how big she was, but maybe 3 centimeters.
Okay, so maybe it's
So,
still like on the
yeah.
cusp of like sort of slightly normal. The left atrium looks kind of small. LV, I can't see all of the segments, but at least the basal segments seem to be thickening appropriately. There's no obvious regional changes here that I can appreciate. Anything else?
That's it, actually. Pericardial effusion, pericardium, and
And the
descending
thoracic,
air.
yeah.
Okay, go on to the next one.
Okay. So I think we've got a parasternal short axis. Looking at the great vessels, so you can see the aortic valve in the center there. There again looks like there's sort of a circumferential pericardial effusion. It looks like it's compressing the right atrium and the left atrium to me. It's dancing in there, yeah. And again, sort of this loculated or lobular echogenic material in the just overlying the RV, I guess, or the RV outflow tract. It's a tricuspid
Or is
aortic
it just
valve,
part of the RV wall?
or it could be the RV wall. It's yeah, you can't really tell at this point.
No, there's a lot
There's something
of
funny about
new-
it, yeah.
There's a lot of near field clutter.
Right.
There.
Yeah. But I don't see any like other weird, like no septations or any other echogenic material in the pericardium. So it looks otherwise fairly clean. Can you think of anything else? Yeah. Can't speak to any regurgitation, but it's just like going crazy in there.
Effusion.
Mm.
So that's just a still shot during the maximum collapse of the RA.
Of the RA. Oh yeah.
So
yeah.
we'll have to look at,
And
the
it's during
collapse.
systole, right? So
so
yeah.
if it is more than actually like 2/3 of the cycle, then it is
More than
significant.
1/3.
More than
1/3
1/3
is very significant.
Yeah. So yeah, cool.
Yeah.
All
Actually,
right.
turn down the far field gain and see if that pericardium stays bright. It's
Yeah.
Yeah.
Yes.
So that's almost certainly far field gain.
It's just far field gain.
All right. So this is I think again a still shot of personal short axis view, but
Yes,
looking more at
2.4
the.
centimeter.
So it's severe or like
Large.
large,
Large.
severe, large.
So
Sorry.
more than half a litre of something.
Right. Okay. Yeah. It's bad.
Is it?
Is it though?
It's not changing them clinically. Is it?
Oh. Okay. So we've got a apical 4-chamber view. I don't know what's this thing going on here. This is something.
This is the atrial collapse, which
But no, what's that? Is that collapse or is that a lesion?
I
or
don't
what?
know about that, but I think atria is collapsing.
Yeah,
it's
Atrial is
like
definitely collapsing.
Yeah. With the
I
effusion.
think the ventricle is also collapsing
Yes.
as well. Left side doesn't appear to be as much. I can't really. I might have to slow it down to see if the left atrium is as well.
So now you can assess
actually, like,
the
There.
Yeah,
Yeah.
there it is. Yeah. Ooh,
Oh
it's
my
just
God.
dancing. It's just like wobbling, doing the worm.
and then you look at
It's harder to appreciate the pericardial effusion in this view.
it's
though.
there actually, like,
It's
so
just
you
sort of
can
there.
move it slowly, then you will see the atrium. And then just move bit forward.
Yeah.
Because you can see how the heart's swinging within the pericardial
Yeah.
fluid, so it's going in and out of plane.
Mm. So I think there's probably also
That is
left
more than
ventricle.
1/3 of the
It's quite a
cycle.
large pericardial effusion.
so you've picked up everything there. So now move on.
Okay.
Oh, that's just a still shot to show the degree of collapse
Yeah.
at its maximum.
Okay.
See, I've done the
So
measurements for you.
yeah. So we are looking at the
We have also done
tricuspid
the variability. We
E-way.
have done the 55% variability.
Yeah.
Yeah. So this is again like sort of this is analogous to the pulses paradoxes, right? Like the respiratory variation.
Yes.
Yeah.
So, but on the right side of the heart.
Yeah.
So
Yeah.
what's the threshold for significance?
It's 40%. So if it is more than 40%, then it's tamponade.
Yeah.
I'm just telling Dishani the numbers because she
Yeah, I missed the
detail.
best. Yeah, sorry about that. Okay, so this is a subcostal view. And again, we can see what looks like a circumferential pericardial effusion. And yeah, it still looks a bit funny. It could be the RV, it could be something weird in the pericardium, a little bit of something echogenic in there. RV looks dilated. The RA is definitely collapsing and the RV is collapsing as well. Let's see where it's collapsing the most. So like the sort of
Yeah.
diastole.
Yeah.
Is this person sick or what?
I'm well.
Tachycardic, I think was well, at least what we got.
109.
Yeah. It's doing a little worm. It's doing a little, yeah. Yeah.
Okay,
So
moving on.
already.
Moving on. I think I just took another shot.
So this is another subclass. I guess sort of order off
Doesn't really
axis.
tell you anything different.
Subcostal view.
And where have I got the cursor?
So you're looking at through the right ventricular wall.
Yep, so that's the top bright line.
Yeah.
And that just,
Shows the collapse during.
yeah.
Yeah. Oh, very cool. Nice. Yeah.
Okay, now this,
Something's in the.
I didn't
IVC.
realise it was
Yeah,
actually a
in the
clip.
IVC.
I thought it was a static shot, but unfortunately it's a clip. But the maximum black bit is there, which is 1.6.
6.
But what do you think of that shot of the IVC?
There's something, some kind of echogenic material.
Yeah,
Highly suspicious of thrombus to me.
or something.
Or
Clot,
something. Or clot.
clot,
Yeah.
yeah. So what do you think? What's your conclusion?
This poor lady has large pericardial effusion and a clot in the IVC. Could this be related to the interventions that she's had for her angioedema, for angioembolization of her
I
angioedema?
think she probably just bled and it got carried through into the IVC.
Okay.
She just bled
Mm.
into the liver. So what?
Where would the pericardial effusion come from in that context? Okay. Okay.
So what's your conclusion?
Conclusion is that this woman is very unwell and she should probably have her pericardial effusion drained.
So
It will be large pericardial effusion.
Large
Large
pericardial
tamponade
effusion with specific features of tamponade.
Okay, sure.
So go on to the postscript.
Oh, that's a bit
So we
sad.
never found out what was the cause of that.
Oh, I don't
Autopsy.
remember now. I don't remember. Yeah. All right, Kalpana, your turn in the hot seat. Everyone's allowed to help.
ADHD treatment, 32-year-old man, ADHD treatment as a child, 5 weeks of myalgia and arthritis, elevated dsDNA and positive P anchor in outpatients, started on prednisone 15 milligrams daily. He presented to ED a day ago with fever, hypotension plus acute kidney injury. And echo was done on 13/11. All right, so this is the parasternal long axis view. We can see actually there's something in between in the pericardial anteriorly as well as posteriorly. I think this is the descending aorta, so it is in the pericardial space. Otherwise, RVOT is frozen.
He's already left.
Oh, yeah. Well, you see it, you can see it.
Yeah.
What did you say?
So RV is contracting well. Don't see much of the aortic root is not seen. It's visualized very well. And this is the LA and this is the LV.
So
This
in
pericardial
terms of the
effusion.
comparative size of the right ventricle, the aortic root and the left atrium, they're all about right?
It's hard to
You reckon?
say.
Yeah, they are.
Relatively
Yeah,
speaking.
yeah, relatively speaking. All right.
Yeah. Because roughly speaking, the AP diameter of the left atrium should be about equal to the aortic root.
Yep.
Should be about equal
To the RV.
the LVOT if you measure it from the aortic root up like that. So they're all about much the same. Just a rule of thumb.
That's it actually in this
Okay,
way.
moving on.
This is a sternal short axis view at the level of mitral valve.
Just get it going again. So just press, yep, that one.
And I can see that there is, I can see the effusion on at least over here, and might be actually around the right ventricle as well. Yeah, it's around the right ventricle as well.
What do
And
you
there's
think of the
thickening of the
septum?
pericardium. So septum, the movement of septum is maybe a little bit of septal flattening, but not very obvious like the previous one which bended. Yep. Septal flattening in a little bit, septal flattening in systole. Maybe I'm just slow it down. Maybe here.
So there is a bit of
Septal flattening. Yes.
systole, isn't
Yes. Yes.
there? Okay.
Right. Have I missed anything in this?
No, carry on. Well, you could comment on the contractility,
Oh yes.
which is
Contractility.
hard to say,
Say,
isn't it,
yeah.
with all the bits moving
Yeah.
in all directions. Anyway,
Yep.
move on.
All right, so this is the mode through this LV. This is RV and this is LV.
So this is again another good M mode position
Yep.
to show yourself any collapse of the right ventricular wall.
Okay, so we are looking, this is expiration, this is inspiration. Is this normal or is it more than like it is a normal here, the collapse? Because we'll have a little bit of collapse anyways, isn't it?
So it seems to be more related to respiration,
Respiration, yeah,
rather than
Cardiac stuff.
yeah.
yeah, cardiac
So
cycle.
and it seems to be at
This
the
looks
peak of
like-
inspiration.
Yeah.
Because that's what we'd expect.
Yes,
No, it's the reverse.
okay, yeah, if he's in,
You would have increased.
But what you can say is there does seem to be respiratory
Variation,
variability, even if it's not obeying the textbook.
When you take a big breath in, you're opening up the size of your thoracic cage. Does that, with increased negative intrathoracic pressure, does that then allow your pericardium to go out a bit more? You got that negative pressure, therefore you get a bigger.
Not if you've got constriction.
Constriction. Yeah, if your
Yeah.
pericardium's constricted.
Because if you've got constriction, you don't get transmission of the intrathoracic pressures into the heart
Yeah.
quite so much.
Yeah, because you're limited by that constriction.
Yeah.
right, so in the next one we have the effusion size, which is 2.4 centimeters, so it is again large effusion. And what else? More than 500 mils. So this is the 38% variability in RV output. So it is less than 40%. Tamponade physiology, if you look at it,
Okay,
Like
so
it might not be
which phase
tamponade.
of respiration do you think it matches? So when is the
Greatest.
RV outflow greatest?
over here, the,
Which
X.
is inspiration
Ins-
or expiration?
this will be,
Inspiration.
Yeah,
this will be inspiration and this will be expiration. Yeah.
yeah. So you've got marked respiratory variability there.
Yeah.
So that kind of narrows your options down to tamponade or constriction.
But if it is actually more than 40%, it is just sitting there at 38%.
I think
So
that's
it
numbers.
can be-
Numbers are guides.
yes.
Not height,
Yeah.
right?
So it can be,
But you've got more than normal,
Yeah.
yes,
and you've got a pericardial effusion.
effusion.
Yeah.
Yep. Okay, so this is the
Okay,
Fold
so the most
chamber, apical
important
fold
thing is
chamber
watch
view.
that bounce.
Yep, yeah, this one.
So that tells you there's significant interventricular dependence with that bounce.
Yep. And this collapse of RV as well here. Oh, sorry, RA. And this bounce you're talking about, the interventricular.
The LV doesn't look like it's thickening all that well.
No,
That's
you
just
can't
me.
see the apex thing.
Yeah.
Yeah.
The base is alright, but midsections are probably.
So I think there's RA collapse, there's some RV collapse as well. And there is, there might be like septal, there is septal flattening and
Well, it's
So
not,
with
you
the
call that
interventricular
you
dependence.
call that septal bounce.
bounce.
Yeah.
Okay. The valves are looking okay.
Is the myocardium looking a little bit sparkly? Speckled.
Yeah, so over here, and there is the effusion here.
Anyway, moving on.
Still shots.
Yeah,
Looks like
still.
Yeah,
Yeah,
it's
still
just
shot.
a few still shots to show the degree of collapse. So you can just go tum tum tum.
Oh yeah,
yeah.
yes.
she's all that. Yeah.
And then we have got EA variability of more than 68.
So that's
So that is
that's sizable.
Yep.
Yeah. It's a lot.
What's the lateral?
I have gotten the measurement here.
So it should be greater than 7 centimeters per second, and it's actually 13 centimeters per
yes.
second. Okay, move on to the next one.
The lateral
Measure
should be-
lateral. The
should be
lateral
bigger.
should be greater
Greater than.
than a septal.
than the
Yes.
septal.
19% variability.
Don't get hung up on the numbers quite so
Yep,
much.
yep.
It's just that
Not as
Trend.
much
it's not as much when
variability.
you're just taking the peak velocity.
Yeah.
There may have been more variability if I'd actually done the full VGI.
Yeah.
Yeah,
Anyway, so
But
what
it
do you
is there,
think? Moving on. Is there any hepatic vein in this one? Move on, move on. Still shot coming up. God knows what for. Oh, that would be the ventricular.
Collapse, yeah.
3.1 centimeters, collapsing down to 1.8.
8 centimeter. Yes,
Ooh.
it is
Not quite 50%.
quite 50%.
No, not quite. If 50%, it doesn't rate.
This, yeah.
Yep. And there's the
And now
hepatic
we have got
vein.
hepatic vein, and here we have got reversal of the diastolic flow over here. And this is also exaggerated.
So I don't know
So this-
why the respiratory
Traces.
trace isn't there. I don't know why. Maybe it died.
Yeah, but
Anyway,
this
so you
reversal of
can't, you
diastolic
can't
flow.
really, yeah,
No,
you can say there's some diastolic flow reversal,
Reversal.
which seems to be vary
Yeah.
over time. That's about all you can say. Okay. Okay, so this is something, so obviously this person went on to have a drain put in.
Mhm.
Now show that clip again.
Just press play.
So you want to check where the drain is, so you inject agitated saline. Where do you think the end of the injection point is?
It's coming here.
Yeah, where is it?
Oh, we are injecting from the drain. So it's coming. I don't know,
that
actually.
That's the drain.
Yeah, it's not looking at
I
drain.
don't know. That's
I can see it here actually.
You can see the
That's
bubbles
bubbles
there.
there.
but
Yeah.
Where is that?
is it in the heart or is it outside the heart?
Right ventricle.
Yeah, it looks like
Pretty
right
well.
ventricle to me.
I don't know.
Okay, have a look at the next one.
Next one.
Intracardiac bubbles, I think.
I think you're on the same one.
Yeah, press it next again.
79.
Oh, now the bubbles.
Where are the bubbles?
They look
There.
like they're in the pericardial space there.
Assuming the RV is completely down,
Yeah.
it's a better shot.
Yeah, it's a better
It's a
shot.
safe shot.
Yes. Yes.
You wouldn't know where the other one was. would you?
No.
Hmm.
Okay, and there's a postscript.
Oh, wait. Keep the postscript. So, penicillin dose was increased to 15 milligram per day, and the resolution of effusion within a week post drainage and increased immunosuppression.
Mm.
So we had an autoimmune pericardial
Effusion, which was drained because it was large in size and causing pericardial tamponade.
Yeah.
And it responded to prednisone and immune suppression.
Okay, that's it. We're all done now.
If you learnt something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @Echonepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.